There's a principle in like youth program design that they talk about all the time that's pleasantly frustrating.
Okay.
And that is something I really try and ascribe to where like this is hard, I don't like it, but I want to come back for more.
Hmm.
And if we can check that box, whatever it may be, then we're probably going to be able to use that as a little bit of an anchor to make some progressions, whether it be into range of motion, load, or even like how much you just trust moving.
Guys, thank you so much for downloading this podcast. Really appreciate all the support, all the feedback we're getting. This podcast is growing like wildfire, so thank you so much. I want to ask you, as always, share it with a PT that is looking to learn, looking to get better. Today's conversation is with Derek Miles. Derek did both graduate school and his residency at University of Florida. He then moved to Stanford Children's, where he was advanced clinical specialist. And now he has his own private practice in Ohio called Miles Rehab and Performance. This guy is a straight shooter, a wealth of knowledge, and you're going to learn a ton by going through very specifically how he approaches general population low back pain, some of the myths and concepts that are out there that he totally dispels. He does a great job. He is very to the point and taught me a ton. So without further ado, here is my great conversation with Derek Miles. Welcome back to the True Sports Physical Therapy Podcast. We got Dr. Derek Miles with us. He runs his own clinic. He also does some stuff for Barbell Medicine. Derek, I don't usually do this, but with a guy with as eclectic of a background as you have, why don't you tell us how you got to where you are today? Because I think this story is really interesting.
Well, the elevator speech, I did my physical therapy school at the University of Florida and then did an orthopedic residency there afterwards. They kept me around. In 2015, Quinn Hennick started Clinical Athlete, and I got involved in their community. And there was a very active forum talking about some of the current research topics and discussions related as such, and kind of made a name for myself in the forum, for lack of a better way of saying it. And then met Jordan Feigenbaum and Austin Baraki, who were the founders of Barbell Medicine. And they asked me to come work on the rehab side of that. I was at Stanford Children's at the time, working as their advanced clinical specialist. And then because a lot of my decisions are dictated by my wife, when she got her fellowship at Cincinnati Children's, we moved to Cincinnati. And for a time, I was just doing Barbell Medicine full time, but now I've opened up my own clinic inside of RTS Barbell and have honestly one of the best facilities I have ever been in with which to work with athletes.
I love that. Okay. And it's good to hear that it's not just me who has someone else kind of dictating how our life unfolds. So I'm glad to hear that. Tell me what took you to, first of all, why don't we start from Florida? What made you do a residency? And if you had to do it again, would you do it?
I think I came out of PT school knowing that I still had a lot to learn. And, I'm sure most listeners of the podcast, there's always that thing getting batted around about how we don't get a lot in terms of programming, working with actual sports injuries in school. And if you think about it in the grand scheme, sports is 5% of PT. So it kind of tracks.
Yeah.
So I gravitated towards that. Plus, there was a clinician at the University of Florida named Tim Shea who did a lot in the spine side of things. And Tim was just a phenomenal mentor to me while I was even in PT school. And the opportunity to do a residency under him was extremely appealing. I understand both sides of the pro-con residency debate. And if I could go back, I absolutely would do it again, because there's no way I would be where I am today without having done it. Yep. But I certainly think I was also fortunate enough to be in a unique position at the time.
Yeah. I talk to new grads about this a lot, and I think it is individualized to make that decision. Sometimes I look at it and I'm like, dude, you're going to learn more if you join whatever outstanding outpatient clinic and you have good mentorship. You're going to learn more there than you would at some residencies. I think it's also important to note that not all residencies are created equal. I mean, you were there, you saw it. You knew Tim and he would be an outstanding mentor. It's not always the case when you're kind of flying across country and signing up for something you're not sure about.
Oh, absolutely. I think if it were just flying blind, would I have reached out for a residency? Possibly, if there was an opportunity to work with a population I was highly interested in. But let's face it, you come out of school with debt, and it's like if I could have hit the ground running a little bit better financial state, I probably would have went that route.
So. Yeah, that makes sense. Okay, so then what drags you all the way across country to Stanford?
My wife.
Your wife. Okay.
Yes. So I told my wife when she graduated med school, ironically, I would move anywhere in the United States except the state of Ohio. And here I am now. So she matched at Stanford, and I wasn't going to move out without a job. So I stayed at Florida for a little while behind, and then a position opened at Stanford Children's, and I got accepted for that. Moved out there, did what I did for 3 years, and it was serendipitous because it also put me in close proximity to Jordan because he was in Santa Cruz at the time. So got to get to know him a little bit better as I was coming onto the company.
Yeah.
And so things just kind of worked out in the right direction. So
Yeah. Yeah. Well, listen, it always works out. So, okay, talking about what you learned in your residency and then how you apply it to your everyday. This buzzword, this concept of pain science is out there. I never really know what the hell it means. So let's start there. Define pain science for me, and then tell me how you use that knowledge or don't use that knowledge in your day to day.
I think trying to define pain science is likely a fool's errand. And even yesterday, I was reading an interesting back and forth on social media about the IASP definition of pain in individuals, how much they want to ascribe to it or the problems with it. I think a lot of pain science just comes down to communication in learning how to talk to people about what they're feeling, which is a much more like philosophical conversation than it typically is a science. It just has a lot of scientific underpinnings to it.
Yeah.
And while I was at my residency, that way I can just shout out every mentor I've had. I was fortunate enough to be under Steve George, who's published a lot in the low back space, and Joel Bialowski and Mark Bishop. And I was even more fortunate in that they didn't have any active research projects at the time, which sounds like a negative for publications. But as that void was present, Steve essentially made me learn how to edit journal articles. So I had a crash course for a full year in just how to read and tear apart research,
Love it.
which was honestly probably about the greatest experience anyone could ever ask for. And at Florida at the time, we had a lot of active projects going on that I wasn't under, but being affiliated with the recruitment process, learning what's in the sausage, if you will, with the statistical analysis, the problems with recruiting, and even some of the nuance of, we'll just say, the patient populations involved in things, the inferences made from the results. It certainly changes the perspective in how you talk about things. And that isn't good nor bad. It's just much more slants you in one way for how you're approaching the problem.
Yeah. Okay. So, go ahead.
And I was going to say, even since then, I've worked at other institutions who I will not name, and seen how they treat, and they've also published a lot of research, and then seeing the results of their research versus what they say they're doing, and it could not be more discongruent. And it's a little eye-opening because I think, trying to define pain science in the same vein, a lot of us talk about, we do exercise, we do movement with our athletes, but we never get into the nuts and bolts of what that is. And our penchant is always just to assume it's the same thing that we're doing.
Mm-hmm.
And then you get into an institution where you see that, like, there is no loading parameters. There's not a lot of focus on any type of progressions as you're going through the rehab process. And then you see some of the research that comes out of that, and you're like, well, that checks, but we weren't really doing exercise at that point.
Okay, so give me more specifics there. So without naming names, give me kind of examples of what you were able to see there and some of the holes or the misconceptions upon which they were practicing.
Well, I saw an individual for the first 8 weeks of ACL rehab who was doing open chain knee extension with 40 pounds. And by the time I left at 8 weeks, or stopped seeing him, and then saw this individual again at 9 months, and he was still doing open chain knee extension with 40 pounds. That's the lowest hanging fruit. But even in, how the exercise was documented, it was just an X next to the exercise. So no sets, reps, intensity, rest, or anything like that. So, it's not, it becomes very hard to discern how hard that individual was perceiving it to be, or even like how challenging it was, not only from a true like effort perspective, but even, fear, things like that, because it's just like, we did the thing.
Yep. You did the thing. Okay, so it wasn't really qualified nor quantified as to how that individual was progressing. And so in that example, obviously we would want to see that patient progress towards closed chain work, progressed appropriately with load, with volume. How were they looking at 9 months? Like, was there an actual deficit because of that? Because they weren't doing that?
Oh, their isokinetic test was not spectacular.
Okay. So give me, because I think this is an important topic because we talk so much about evidence-based medicine. And while we're given some skills and tools in graduate school to discern good and bad information, give me the 2 or 3 big hitters that you saw that helped you delineate what is good research, what is meaningful coming out of the literature to apply to your patients.
The driest one of it is honestly like learning statistics. And it's one thing in for the first 14 years of my career, I had full access to PubMed. And that is a very unique position. And so you can go through the whole thing. Whereas a lot of what gets, and it's changed over the last 5 or 6 years, I would say a little bit more for the better, but it used to be just abstract hunting.
Yep.
And it's not until you get into the methods, you learn what confidence intervals are, you learn the dissertation that can be given on why p values do or do not matter, that it starts slanting in one way. So I think it's always hard to distill it down to 3 things, because it's a little bit of everything. And it's a lot of what makes for good fodder on social media is hot takes and black and white stances, but all of this has gray area to it. And it's not that any one thing really slants hard in one direction or the other. The other issue is science is set up to prove things wrong. So it's a lot easier to say that something isn't the way it is than to say it is. And we're all looking for answers. And if we're looking for an answer, we want something to be right. Mm-hmm. And that's just not not how the program is designed. There's always going to be more questions to ask.
Yeah, it's a lot easier to bring problems than it is to bring solutions. So I think that bears itself out in the literature. So, okay, so if that's the case, then how do we go about getting appropriate answers as we're looking to round out our rehab expertise?
Read a lot and argue a lot. And okay. It's not just reading about one topic, because there's fun analogies between how you're going to look at research and even how you're learning movements. Because the more we're willing to explore things, get outside of our comfort zone, probably the more options we're going to have out of it and the better perspective we're going to have. And I learned a lot of it through attending journal clubs, where it wasn't necessarily celebrating the articles, but more trying to tear it apart. Mm-hmm. And the better you get at trying to tear it apart, you start seeing the weak parts and how that might affect how much you want to anchor to whatever the findings are.
Yeah. Okay. So that makes a lot of sense. And it's a very interesting way to go about a journal club and what you can glean from that. How do you keep up with that stuff in your current day-to-day?
I read a lot. And then I do think one place where, I think social media is writ large a black hole, but it is very useful, especially in the X space, for seeing what articles are getting published and following researchers, because that's where they tend to tout some of their stuff the most, and staying interested. And if it's something that's in my wheelhouse or something I might be interested in, and I have a feeling you're probably the same way, I don't even want to know how many text message threads I have on my phone with multiple people in it. And most of the time it's present your thoughts and then see what comes back. And I think some of it is just getting comfortable being wrong, and also getting comfortable with the fact that we might not have an answer to something.
Yeah.
And those two really combine to move forward, because a lot of us, we want that feeling of confidence. We want to feel good about what we're reading, but the more comfortable you get at going into it this is a learning experience, versus going into it with I want to know what I'm talking about. It is that process versus outcome that you hear in so many different spaces, and the more we're focused on the process, likely the better our outcome is going to end up being.
That's a true growth mindset. That's really awesome to hear. If I'm a newer PT, who are some of those researchers that I need to be following and digesting their content?
I would say Joel Bialowski, Mark Bishop. In the tendon space, you have Magnuson. I'm probably going to butcher some of these names. Kiersgaard, and then in the youth sports stuff, I think Avery Feigenbaum does a lot of really good stuff. And if you start there, it really is kind of getting into the interest of where you want to go.
Okay. Those are great names. So I highly recommend anyone listening just do a quick search on those because I'm sure you'll find a whole bunch of gold. So as you're constantly doing that, give me something that coming out of Stanford or since you've been in private practice that you've really changed your tune on in the last, call it 3 years.
I would say I probably softened on some things more than changed my tune. I might just be playing in a different key
Okay.
at this point. I probably would have been a little bit more hardcore about some of the parameters regarding strength training 5 years ago and beat that drum a little bit harder. But the research really just slants more and more towards we just need to get people active, and everything else is arguing about the details. And I think if you would have talked to me 5 years ago, you would have heard me slant more towards it needing to be this specific thing. And I would venture I'm much more generous with that now.
Okay. So specify when you say that thing.
Like even the principle, and I realize I brought this up a moment ago and I'll work against exactly what I said, but like things like progressive overload. Like in ACL rehab, I would argue that is a very necessary thing if we're trying to return to high level sports and get our whatever metrics we're trying to hit for this individual. But for somebody who is just trying to get active, trying to live their life, it likely doesn't matter as much. I mean, physical activity guidelines just say 2 days a week of strength training. It doesn't say 2 days a week with a top set of 4 at RP8, drop 10% and hit 2 additional sets. It's like we like to overcomplicate it, or like, that it needs to be in a specific way. Like I've never ascribed as much to the like it has to look perfect technical side of it. But one thing that has certainly changed since I've gotten into this clinic is there's a large bolus of strong men here.
Mm-hmm.
And if you watch strong men train and see the implements they use and the techniques they have to use, you realize real quick that a lot of our conversations about neutral spine go out the window really fast.
Yeah. Yeah. Okay. Interesting. So in that population, say you have a Gen Pop low back pain patient. Tell me how that colors your interaction with the patient in a given session as it pertains to mechanics or form.
It really depends on what their goals are. And if we're just trying to get more active, then I'm going to try and have plenty of conversations about, working towards whatever we want to consider optimal technique. And I think if you get 10 coaches in a room, you're probably going to find 9.3 different opinions on what that would be constituted as. But I'm certainly going to be much more permissive because I think as much as we talk about form, kind of the denominator in a lot of conversations is what is hard for this individual.
Okay.
And
So you're challenging that which is hard and progressing them through or to that which is hard in a given movement versus here's exactly where your feet need to be. Here's what your knees need to be doing, et cetera.
correct.
Okay. So that makes a lot of sense to me. How do you then go about coaching it? So give me a reel, for instance, in which a low back pain patient walks in. How do you dip your toe into the water of we're going to try X movement?
Most of the time, it's really contingent upon what they've done in the past. We can scale range of motion, load, tempo, all the fun things out of it. If someone tends to be pretty fear avoidant, it tends to be a little bit of a mix and match on things that's going to make them feel safe and things that's going to make them be a little bit scared.
This sounds like a pain science conversation. I like it.
Well, I mean, most everything is that communication. And,
Yeah.
I don't think anyone you need to like full send into the fun house and have the scariest session ever. But odds are if you're not, there's a principle in like youth program design that they talk about all the time that's pleasantly frustrating. Okay. And that is something I really try and ascribe to where like, this is hard. I don't like it, but I want to come back for more. And if we can check that box, whatever it may be, then we're probably going to be able to use that as a little bit of an anchor to make some progressions, whether it be into range of motion, load, or even like how much you just trust moving.
I like that. It reminds me of a conversation I recently had with a newer clinician where, they were getting hell bent on a certain amount of weights or exactly what exercise to prescribe. And I was trying to dial them into, you just need to find that which challenges your athlete and allows them to come back for more. Right. And that usually sets yourself up for a good session. Do you go after, I guess let's talk about core engagement as a new grad, right? A patient comes in, they have low back pain. You want to teach them how to brace their core. Like, how does that conversation go at Miles Rehab and Performance?
It normally starts out by me asking that person to define core.
Okay.
And it ends with a long silence. And, there's even research looking at like how well we are at defining core. And it's one of those words that we like to throw out that doesn't have a true operational definition. And I tend to try and stay away from those words. And I do think there is some utility in teaching like some bracing things like, pushing out against or whatever. There's a million different ways to have the conversation with someone, but it's pretty rare that I ever think to myself, I need to get your core stronger. In fact, I don't know that thought has crossed my mind in the last decade.
Okay. So if you're not palpating their transversus while they're doing dead bugs, what are you doing?
We're doing things to challenge them. It might be lunges, it might be squats, it might be deadlifts. I mean, if you look at it, like we could basically make a fun little spectrum between like a Jefferson curl being the most nihilistic hinge pattern and the most beautiful deadlift you've ever seen being our ascension to nirvana. And everything else follows between those two. And it's just, where do we need to live? And probably what matters more is how safe they're doing it and like what is the overall load out of it. Like I think most of us would be a lot more comfortable pushing into like trying to find the upper bound of what is tolerable for that person on a good set deadlift than we would for a Jefferson curl on day one.
Yep. Okay. So that makes a lot of sense. Now you are describing the beautiful art that is our profession. How do you boil that down to a new grad? So if you have a new grad that's applying for a gig at Miles Rehab and Performance, where do they start if they don't have all these years of experience?
By watching and talking. And then, you give them scenarios. I have a newer grad that comes and shadows me. And part of that every time is she has to take the pen on the whiteboard and we're going to walk through scenarios and she has to think through it. Because I already know what's bouncing around in between my ears. It's a scary place. No one else needs to be in there. I don't know what's going on between hers. So we need to like pull that out to figure out what it is. And really at its heart, that's no different of an exercise than me teaching someone to deadlift. It's just, we've now scaled it to what's in between your ears versus can we pick up the weight?
Okay. I love that. So a general populations, a real desk jockey who is not living in the gym but has low back pain, your entry point to watch them move on the floor, or let's take a step even before then, what's your assessment look like?
I play the good old rolling out red flags side of it, and it is the do you have anything that is going to get you outside of my scope of practice? And even if you look at like lumbar flexion extension range of motion, like, yeah, we have normative values for it, but odds are I'm going to try and get these people to in range with what I'm doing eventually anyway. So in our standard error of measurement tends to be like 10 degrees anyway. So how much am I really anchoring to that being like the main KPI I want to go after? And once again, I'm very fortunate at RTS because this is like the most stock gym that I have trained out of, and the owner, like, I have been in many clinics where I have had to have hard conversations about trying to get something like a knee extension machine. Yep. And we had one here that the benchmark on it was you had to have about 30 pounds of ability to kick it to move it, which isn't great for a lot of post-op starting points. And I just brought that up in conversation, and like 2 weeks later, another one showed up.
Love that.
Like if our healthcare system worked like this, Man, it'd be amazing.
Yeah.
But to back to the point, now that you've got me tangential a little bit, like that individual, we might get on the back attack on day one. We might, like, we have a car deadlift here, essentially, that is like, it's set up for strongman training, but it also is about one of the best ways for entry level training someone to pick something off the ground. So we might go over to that. And a lot of the read on where we're going to start is how active that person is, and then how or where, since we've already had 9 spectrum talks, where on the spectrum of avoider and confronter they are.
Mm-hmm.
So if they are pretty fearful of movements, I'm going to try and be as safe as I can on day one, because I want them to go back and see that they can do stuff.
Mm-hmm.
And, it may be that if I'm going to teach a deadlift that day, we're using a training bar and the red 5-pound training plates. And
Mm-hmm.
it's not a big deal if that's our entry point for the day, but it's not even honestly sometimes the deadlift, it's the conversation around it. It's
Mm-hmm.
like, oh, this was scary to you. Look, you did it. Or, some iteration of that along the way.
Yeah. Okay. So if that is the ideal, let's say, what mistakes do you commonly see or hear that maybe your more standard PTs are committing when dealing with this low back pain patient?
I think a lot of how we've been taught, and this isn't even unique to low back pain, is, we have to start at step one. And that's the like super low level, whatever our 3 to 6 exercises are that we can bash to no end. And I do think there's some utility in those sometimes. But if I can skip step one, I'm going to skip step one. And most individuals can skip that step.
Mm-hmm.
And it's about finding that entry point. Like, we talk a lot about finding the entry point, but then especially in the newer grad side, it's always the simplest thing there is. Whereas a lot of times we can start a little further down the road.
Yeah.
And if that's the case, then we're truly meeting the person where they're at versus starting at the beginning of the trail and then hopefully progressing through as we get a little bit further down the road.
Yeah, and as you spell that out, I feel like that is one of the hallmarks that differentiates sports PT maybe from your general outpatient physical therapy experience. It's trying to understand where that athlete is and what they're already able to do, and kind of skip those things. Then you're going to have an interaction with the patient that is far more meaningful, because you're meeting them where they are as opposed to reading kind of through your textbook. And I think that's one of the differentiators. There are many of them, but that sets apart, let's say, sports PT from your more standard practice. Would you agree with that?
I think I know plenty of people in different settings that are very good clinicians at skipping steps and starting where they're at. So I don't know that I would say that's unique to sports, but I also think, a lot of, for the positive, I think in the past 10 years, sports PT has been much better about looking at the whole athlete and realizing that, there has to be cardiovascular training for a post-op knee. They have another leg and 2 arms and a trunk that we should probably be doing stuff with. And I think some of us kind of come to that conclusion organically because we get hurt.
Mm-hmm.
And it's that, like, one of the fun questions to ask a new grad is like, would you listen to your own advice?
Yeah.
And if you told me that all I could do was 20 quad sets, heel prop, and some straight leg raises, I can promise you I'm going to be doing something else in the gym that you don't know about.
Mm-hmm. Mm-hmm. And so including that in your prescription would probably go a long way.
Yeah. Or even, asking individuals like what they like to do, or like if I'm starting someone out here, and even in the like symptom side of it, because there's a very gray line between what I would consider my rehab and performance side of the clinic. But one of the questions, or one of the conversations I try and have early on, is like, what piece of equipment in the gym looks interesting to you, or what else did you see someone do that you want to know what it is?
Mm-hmm.
Because not only are you starting to figure out like maybe the style that person's going to gravitate towards for training, but also like, well, maybe this matters to you a little bit more than something else.
This is the psychology side of what we do. I think it's relating to the patient, it's meeting them where they are, and really understanding where they want to get to. And I think there's gold in that. Like there's a tremendous amount of worth just in that description to understand what is it that makes the person in front of you tick, not what makes you tick, what makes them tick, and how do you kind of ignite that fire to let that be a piece of your rehab.
Yeah, I would agree with that wholeheartedly, and I think especially here, because the upside is we have every piece of equipment. The downside is we have every piece of equipment, and I can't tell you how many athletes are like, "Well, I never wanted to try this machine because it's intimidating," and there's
Yeah.
literally like two pins on it. It's just, well, okay, well, that's a very easy barrier to entry to remove for you. Set it up like this. Let's go. And
Yeah.
then they're like, "Oh, I love this machine," or "I love this exercise." Whereas, like, I I would say a lot of PT is really good at overcomplicating things and using polysyllabic words to describe something that is literally just move.
Yep.
And if I'm sure we've never met in real life. I promise you, you give me 10 minutes, I can find an exercise you suck at. I
Oh yeah.
bet. I bet if
That,
I
that
give
would
you
not be
three,
hard. That's
yeah.
not tough to do.
Well, but same, like you could do the same thing to me.
Yeah.
And okay, well, if I'm just trying to establish we have something to work on, then I'm going to pick that exercise.
Yep.
But if I'm trying to establish something where I'm trying to build some confidence, I'm probably going to go to the exact other side of that.
Yeah. Yeah. Now you brought it up previously. Where do you see the line between um, physical therapist and strength coach?
Dude, I don't know if there is one if it's done right. Um, all of my athletes, whether you're here for rehab or not, like we have a total body program unless we have major constraints that are preventing it from happening.
Mm-hmm.
And we're trying to work towards those physical activity guidelines. We're trying to work towards whatever specific goals you have. Like we have a running joke among the rehab guys at Barbell that like if you get a knee pain or a knee issue, it's time to PR that bench press. And we have extra time to work there, so we might
Yeah.
as well use it while we can.
I love that. That's really interesting. I totally agree with your response to that question. That an outstanding PT is an outstanding strength coach, and it's almost vice versa. Like maybe without like the doctorate behind your name, but in terms of practice, they're really one and the same. Understanding pathology, understanding movement dysfunction, etc., should be a hallmark of outstanding strength, and vice versa, right? Like PT should be able to understand that strength concept, how to load appropriately, etc. So if you did a great job of explaining and breaking down the way you might approach a low back pain patient, talk to me about where we swing and miss with return to sport prescription.
Oh man, how much time you got?
Hours, Derek.
Yeah, I think we miss a lot with knowing the paradigms of the unique sport and the demands of it. And I would love to think that even in the like, how do I say this without being me? Uh, I think we miss a lot of the like cardiovascular training components, a lot of the power components, and sometimes I don't think it's the PT's fault. I think there's constraints that are in a 1,500 square foot clinic, and you're not going to be able to accelerate that individual up to anywhere near full speed.
Yep.
So they're going to have to get those exposures on their own, which is predicated on you being comfortable letting them get them on their own.
Yeah.
And so there is that paradigm of like participation, practice, play that I think is a good way of reintegrating things. And we don't have the metrics to slowly ramp people up into getting back to what they're doing and the demands of it. Like right now, I have an individual who is coming back from an ACL who's a wrestler. And as far as like exposure to sports, wrestling is not my strong suit. So once a week, his dad and I have a conversation that's like, what drills do you want to do this week?
Mm-hmm.
But and he's telling me what he wants to try, and we're going through and yes, knowing them, because I can promise you, if I lay out drills for him, I'm going to miss a lot of exposures that he's going to need.
Yeah. Yeah. Well, good on you for having the humility to have that conversation as opposed to pretending like you are a wrestling coach, or someone with outstanding wrestling acumen. So I think that's also a great tidbit of advice to share. Like, know what you know what you don't know, and lean on those who do know, even if it's the patient's parent, to get real insight as to what it is that patient needs to do. What about maybe some gaps in return to field sport?
I would say the average return to field program likely does not meet the load and intensity of what people are going to get exposed to on going back. And we can do drills till the cows come home, but if you're going to be out on the pitch, you're going to have to go hard,
Yep.
and we need to be going hard in the gym. And I think it, back to I would almost push back on you to define what you're even saying with the movement dysfunction component of it, because I think sometimes we expect these ideals, whereas a lot of sports is really predicated on getting in like quote unquote dirty positions.
Yep. Yeah. And
And
and by dysfunction, I don't mean, hey, your knee is falling into valgus and we cannot have that. I mean, you're missing range of motion at your knee that needs to be there.
yeah, and that I would perfectly buy on, but I think a lot of our return to sports stuff is probably a little too clean
Yeah.
in that it's closer to drills instead of needing to react to things. And I think there's been a lot of movements in the right direction recently with some of the content and around like having athletes catching things that are lighting up in the air and the dual task side of it.
Hmm.
But I would kind of argue that like keeping your head up as an athlete is just good coaching.
Hmm.
Like it's not necessarily we need to church it up. It's like, hey, sports happen up here. Maybe we should be up here as well.
Hmm.
So
No, I think that makes a lot of sense. You talk about the need, and capacity of an athlete when they return to the pitch, and that we don't necessarily do a great job of matching that during the rehab process. How do you include that in your rehab?
for a lot of my people, the first conversation is how many days a week were you training prior to this going on?
Hmm.
And if it's 5, if it's 6, I need to meet them at 5 or 6.
Hmm.
And we'll structure the program according to the time constraints they have. But if it's too short, if you tell me you only have 30 minutes and we need an hour, I'm going to push back on that a lot more. But if somebody wants to train 5 days a week, then we may have our 2 to 3 days a week of strength stuff, our 2 to 3 days or more of some cardio exposures. And it is, once again, it's titrating to what they're capable of. If an individual has no cardiovascular base, then we just need to start somewhere and build up from there. If someone is really bad at absorbing force, then we're going to push some more like deceleration stuff. And it's making sure that you're checking the boxes for the needs that they have. But once again, I want to be really clear here that I think sometimes we get a little bit too far in the weeds on how we want to parse this out. And it ends up being this like 1-to-1 where we find one deficit, we give one exercise. Well, sometimes it's like, well, how can I check a lot of boxes with one thing?
Hmm. Hmm. Give me examples of that.
Well, so if I need to work on some capacity and we also need to work on some deceleration, I might have an athlete do like a 4 corner drill where they're obviously having to look at me the whole time. So we are keeping their eyes up,
Yep.
but I might push their splits a little bit longer than I would if I were trying to really drive like max force production or like big decelerations.
Hmm.
Or sometimes on the rowing side of it, like I was a collegiate rower, so you tend to coach the things that you are also comfortable with. So a lot of my post ops are really good on an erg by the time I'm done with them.
I bet.
But it may be pushing out some of the steady state stuff or using something like a stroke cap. So if I make you go at a 22 stroke rating, like you're going to have to drive off the slide every time. So
Hmm.
we're going to emphasize more of that push than we are just keeping your heart rate up. And there's ways you can gain just about everything. Like almost all of this comes down to a scaling problem. And like I would say there are no stupid goals, but there's a lot of stupid plans.
Okay. Okay.
And like if you wanted, like I've had 3 athletes in the past probably 2 or 3 years run an ultra marathon and deadlift over 2 times body weight in the same week. which
Love
is kind of objectively crazy.
it. Yep.
But like, I think the shortest time horizon we had for any of that was 9 months, and they all had at least done a half before we started down this road. So,
So
like, yeah, well, we can see if we'll get there. Like, maybe, maybe not. We'll give it a run.
yeah,
So,
yeah, no, I appreciate that. How do you handle prescription of home exercises?
so for my athletes, I use an app where, I'll plug Coach RX, which is another iteration of True Coach. And my athletes have to fill in what they're doing and give me feedback. So it ups the accountability. And it's pretty rare that anything is the traditional copy paste where it's the same exercises every time. Like,
Yeah,
we're trying to write a full body program to check the boxes for all the things that need checked.
love that. And I love how individualized that is, and the accountability aspect that you mentioned. That is awesome. How long are your sessions? How much do they cost? Because you mentioned that you're an out of network provider. How does that work? How much thought went into that? I'm sure a ton.
Well, I'm about to make the hair on the back of the neck of some of your listeners stand up.
Yep.
My sessions are an hour, and I charge $100 a session, which every business coach would tell you that I am the dumbest human that's ever lived for doing that. But the bulk of my coaching comes from Barbell Medicine. And so when I started this clinic, it wasn't that I was even approaching it as a business. It was like, I need to get back in person.
hmm
And it was set up entirely as a way for me to start like getting in-person reps again, because as great as the online space is, you miss things in not being there on the fly and needing to adjust, and also in like having organic conversations versus everything being this like it completely went through my frontal lobe and I thought out every word and comma in the response that I gave you.
Okay, so why are you still charging $100?
Because I can. And what's funny is like most of the time, I guess that because I can response would be like the overcharge side of it. And,
Yeah.
but like, I don't feel the need to raise what I do. And also like, I don't want to like price out people. Like I understand like the business, like in why the rate is what it is. But I also don't want to be to the point where like an individual that may only need one or two appointments because it's something that's pretty straightforward couldn't come see me because they couldn't afford the fair market value of what it is.
hmm hmm
Which,
I
yeah,
get that. Hard for me to want to go that path, but I admire it. How's that?
it's like I said, I have people reach out to me all the time about like the business side of what I'm doing here, and I'm like, I am the last person you want to talk to. Uh,
um, I love that. I mean, do you have other PTs working with you or no?
no, just me.
Okay. Do you have a vision of what you want to do with Miles Rehab and Performance?
I kind of like what I'm doing now.
Yeah.
And the capacity I'm at, the athletes I work with, it's great. And I, once again, I understand. I have some friends that are very high up in the business coaching side of it that love just berating me all the time. But like, I'm happy where I'm at. I'm paying the bills. I'm doing what I want to do out of it. So I don't have an inclination to try and drive it any harder than I am.
Yeah, I mean, it sounds like you have a great sense of who Derek Miles is. So that's really laudable. That's awesome. Tell me about Barbell Medicine. Tell me about like that business model and how it functions.
So for that, it's all remote coaching, and it's I think a one-time consult. In fact, I don't know that I could quote you our prices because I think they changed recently, and I'm not sure. But it is an 1 hour Zoom call where I will answer every question the athlete has, go through and generate a program for them to try and follow for at least the short term out of it with some guidance on next steps that they would take, or they can sign up for coaching. And with the coaching, it once again we're in the Coach RX app, and it is me designing the program for them. They're uploading videos, we're getting feedback out of it, we're progressing, we're communicating, we're trying to do all the things we can do. In there, like I have some athletes running 2-day-a-week program. I have more than a few probably running 6, and it's nice. I think from even a development as a sports PT coach, wherever I fall on the spectrum now, like it's good exercise because you are going to write full programs. You're not just thinking about the joint that's in front of you.
And how many PTs function on that platform?
Among Barbell Medicine?
Yeah.
So it's myself, Charlie Dixon, who's a PT, and then Cam Klauser, who's a chiro.
Okay. And so is there visions, and you could tell me that you have no idea, but is there a vision for where Barbell Medicine wants to go?
I mean, take over the world, right? And that
Yeah. I mean, that's different than Miles
Yeah.
Rehab, right?
Yeah, but they're 2 entirely separate entities.
Yeah.
And in there, we do want to expand. We want to have a bigger reach, and we would like to continue to build the brand, continue to put out above average, excellent content, and try and capture the biggest audience we can. It's about the getting what the evidence says out, trying to build confidence in people, lowering the barriers to entry, generating actionable ways that people can be active on their own.
Well, I mean, you're certainly accomplishing that because that's how I found you. So you're definitely doing a good job of getting the information out there. You're so thoughtful in the content you do put out. You're so thoughtful in the way you coach and human interaction. It's a great product. What's it look like on the medicine side?
So there is a coaching arm of Barbell Medicine where it is just athletes that want barbell coaching. And so that's the vast majority of the other side. Austin and Jordan do consults with individuals with medical questions. But I am honestly not aware of the scale of how often or how big. I know Austin is a full-time physician on his own and likely does not have the bandwidth for much outside of that.
Yeah. Yeah. Well, listen, it's an awesome endeavor. And like I said, you guys are putting out great content. So if you're listening, make sure you check out Barbell Medicine if you haven't already. Tell us where we can find you, where we can find Miles Rehab and Performance, and then tell us where we can find Barbell.
Yeah, Miles Rehab and Performance is in Cincinnati, Ohio, out of RTS Barbell. If anyone is local, more than happy to talk. The Barbell Medicine, it's barbellmedicine.com. That's where the vast majority of our content gets published. We have templates that individuals can follow. And for newer grad athletes or newer grad PTs, even, I don't think our templates are bad to look through in terms of learning some programming philosophy on your own. You kind of got to learn the rules before you break the rules. And I think we're a pretty good place to start for learning the rules. And then we're all active on socials to different degrees. The Barbell Medicine main account is just at Barbell Medicine. Jordan and Austin have a podcast that I am on not infrequently and discussing different medical topics and rehab constraints and general health and fitness.
Love that. It's an awesome rehab. I mean, it's an awesome podcast. So I highly recommend everyone take a look at it. I know I learned a ton just in the snapshots that I got. So Derek, thank you so much for your time, man. You taught me a ton. I love your outlook on the rehab world. I love how well you know Derek Miles. It's really refreshing.
Spend a little too much time inside this head. You might change your tune.
There's a lot of great information in the head. So thank you for sharing it, guys. Thank you so much for listening. Make sure you share this with anyone who wants to be an outstanding sports PT. Let us know what you loved. Let us know what you hated. Shoot me a DM on True Sports PT on Instagram. Can't wait to hear from you guys. Bye-bye. Bye-bye.